Assalamu alaikum and a very good morning to all of you. So, how many of you people, when you were in your undergrad years, you first time walked into your OR and you saw this blood-cladded surgeon standing in the OR with both his hands in a human body, which inspired you to become one, and you dreamt of becoming one. You were inspired by that surgeon and you wanted to become that surgeon. Fast forward, when you got into your residency, then you saw another surgeon standing in the OR with sticks in his hands and operating on the same kind of patient. You asked the patient what it was because this is something that you have never seen before. He asked you and he told you that this is called minimal invasive surgery. And the procedure that he was carrying out was being done through a laparoscope. So today what I'm going to do is I'm going to walk you through the fundamentals of laparoscopic urological surgery. So this slide would contain the pre-op preparation, the operating room setup, how you perform the procedure, the physiological considerations that we carry out in adults during the laparoscopic procedure, the complication, and how you train and practice laparoscopic surgery. So how does it all start? When the patient first comes into your clinic, you take a detailed history of the patient, and then his examination is also of utmost importance, especially his medical conditions as well as his surgical conditions. You need to ask the patient whether he's a diabetic or a hypertensive. Does he have any kind of ischemic heart diseases in the past, or maybe he's running one? And also, does he have any surgical history, especially abdominal history, which is of utmost importance to a urologist? So you take the history, you do the imaging, and then you make a differential diagnosis, or you come up to a diagnosis, and then you decide to put your laparoscopic surgical skills to test. However, not every patient needs a laparoscopic procedure. There are some contraindications to this as well, namely rectal coagulopathy, intestinal obstruction, suspected malignant ascites, generalized peritonitis, significant abdominal wall infection, the patient is morbidly obese, he has had extensive prior abdominal surgeries, organomegaly, ascites, pregnancy, herniation, or iliac or aortic aneurysm. Okay, so you decided that you want to do a laparoscopic surgery on this patient, setting everything aside. The patient is fit, the cardiologist has seen him, the anesthetist has seen him, and he's deemed him fit. So in the morning, you walk up into the OR. What do you see? The first thing that you see is a big tower. It's like a shelf standing there right there in front of you. And it has different devices onto it. And what are those devices? You see the imaging system, the insufflation system, the suction and irrigation system, and a monopolar and bipolar system. So now I'm going to walk you through the couple of the devices that we see on the trolley of the pitch. So this is the light source that we see. It's one of the part of the imaging systems. The light source is usually halogen, xenon, and a metal halide vapor arc lamp. The other thing that you see is the camera. I think most of you have seen the camera too. And then there's a LCD. Not for you to watch your favorite movies, but this is a 2D and 3D television that you do your laparoscopic surgery on. With the camera, okay. So, yeah. Okay, so now, with the camera, there's a telescope attached. So there are two types of telescopes, which is used in laparoscopic surgery. A rigid one and a flexible one. And there are three important structural differences in the telescopes. The number of rod lenses that ranges from 6 to 18 rod lens system, the angle of view that the surgeon used, that is type of the telescope, that ranges between 0 degree and 120 degree. And the diameter of the telescope, that ranges from 1.5 to 15 millimeters. So at the bottom, you can see that there is 0 degree telescope that we most commonly use in our practice. Then there's a 30-degree telescope and a 45-degree telescope as well. The ones that we use is 0 degree in our operating system. On the left side, this is the insufflation system. The insufflation system's work is to provide the gas during the pneumoperitoneum. So it shows you the pressure as well as the flow of the gas, which is measured in liters per minute. On the right-hand side, you see the suction irrigation device. With what you suck the blood inside the intra-abdominal cavity. Not only it is used to suction the blood inside the intra-abdominal cavity, most of the surgeons, they also use it for blunt dissection. The irrigation fluid is mostly normal saline or ringal lactate. And sometimes a lot of surgeons, I've not seen in clinical practice, but a lot of times some surgeons might have used heparinized saline, which is used to dissolve the blood clots in the intra-abdominal cavity when there's a lot of bleeding. Okay, so what are the instruments that the surgeon needs in order to carry out a laparoscopic procedure? The number one is the trocar. I'm sure a lot of you have seen a trocar as well. This is called the Hassen's trocar. All right. So the trocar can vary from metallic. Metallic trocars are usually reusable. The other one is an optical trocar, which can be disposable as well. And it ranges from 3 to 20 millimeters in diameter and 5 to 20 centimeters in length. The one you see on the right side is an optical trocar. And you ask why it is an optical trocar? Because you see the sheath of the trocar, it is transparent. You can actually put a laparoscope during the trocar placement and see the tissues and visualize the tissues as well with these. So this is an optical trocar. There are metallic trocars in which you cannot visualize any of the tissues during trocar placement. So these trocars are usually bladed or bladeless. So what is the difference between a bladed and a bladeless trocar? The bladed trocar, it basically cuts the tissue during entry. And the bladeless trocar, it separates the tissue before it enters into the intra-abdominal cavity. And you see that the stellate of this trocar is not that sharp. It's a bit blunt. So it avoids injury to the intra-abdominal cavity organs. So before we step on to the next slide, I would also like to introduce you to one of the techniques that we most commonly use during trocar placement, that is the open technique. So how do you carry out the open technique? The open technique, as you already know, it's mostly perumbilical because the skin is in close proximity to the peritoneum. The entry site is first marked with the trocar shaft. When we incise the skin, we enter the fascia by grabbing the Alice and using a Mayo scissors and identify the peritoneum and incise with a med scissor. We also introduce the trocar after that and we attach the insufflation. The next thing that most of us haven't seen, to be very honest, because we don't use it, is the Verey's needle. And is used to establish a pneumoperitoneum through a closed technique. I haven't used it. I think probably none of you have used it either or have seen it. I haven't seen the Verey's. I have seen the Verey's needle, but I've never used it. So there's also a way to put in that needle and establish the pneumoperitoneum. But the open technique is comparatively much more safer as compared to the closed technique because the Verey's needle can cause trauma to the intra-abdominal organ during placement. Okay, so you need to have some working instruments as well. You see those sticks, the surgeon is standing there in the UR. On the left-hand side, there are a lot of them. Namely, you have the hook, you have the alligator graspers, you have the small dissectors, you have the clip applicators, you have the scissors, and you have a large dissector as well. We also use a monopolar and a bipolar system during the surgery too. On the left-hand side, if you see at the bottom, you see a hook. This is a monopolar device. And the one that you see on the right side is the ligashore, which is most commonly called the sealer. And this is a monopolar device. Sorry, it's a bipolar device. These working instruments are put into the trocars, and they usually range from 3 to 12 millimeters in diameter, usually 5 millimeters, because we put those instruments through the 5 millimeter ports during the surgery, except for the clip applicators, for which we use the 12 millimeter trocars. So to carry out a surgical procedure, you need to have the appropriate gas. What type of the gases that we use in laparoscopic surgery? The most commonly used gas in laparoscopic surgery is carbon dioxide. And why, you may ask? Because carbon dioxide is non-flammable, it is highly soluble in blood, it's easily removed from the system, expelled through respiration, and is inexpensive. The other gases that had been used in the past were nitric oxide. It's not commonly used because it is flammable, and number two, it's expensive. The other most common after carbon dioxide, the gas that is used is helium. But helium has poor absorption, and then again, it is also expensive, but it is non-flammable. Okay? And it is best for patients for COPD, because carbon dioxide causes hypercarbia and hypercapnia. Helium doesn't. So if there's a patient with COPD and you want to operate on, and if there's a complication during the surgery, rather than converting the patient, you stop carbon dioxide and you put in helium if it is available, that is. So the patient is now on the table and you want to perform a procedure. But for that, first, you have to make a position of the patient. So these are some of the common positions of the patient. You can see the first one is the supine position, which allows an easy access to the lower abdomen. The other one on the right side is the Trendelenburg position that is used during pelvic surgeries. The lithotomy position, mostly used in gynecological and bladder surgeries. And the most common that the urologists use is the lateral decubitus position, which is used during the renal and the urethral surgeries. So this is how a lateral decubitus position is made. It is a 90-degree lateral decubitus position. The lower leg is flexed at 45 degrees. The upper leg is straight with a pillow in between them. The body is strapped with tapes, so the body doesn't fall off the table, which is very obvious. The kidney rest and the padding at the pressure point should always be placed in order to avoid any nervous injury. The Foley's catheter should be inserted to decompress the bladder. A naso and orogastric tube should also be used and should be in position, and pneumatic compression stocking should be there on the lower limb of the patient. So this is a complete position of how it is made during a renal or a urethral surgery. So once you have decided and made the position, now you have to make a choice. Either you want to go with a single incision laparoscopic or the standard port techniques. The one that we use most commonly is the standard port techniques. I have rarely seen somebody doing a single incision laparoscopic surgery in my training. Before we embark on doing a surgery, we need to have some pre-procedure check. We need to understand that this is of utmost importance before we start off doing a surgery. We need to know that the irrigation aspiration unit is working, the electrosurgical unit is working, the carbon dioxide tank is full, and we also have some reserve carbon dioxide. The camera is white balanced, and the light source is also working. The insufflation is also checked before starting off with the surgery. The other most important thing is how you approach the patient. If we are talking about renal surgeries, there are two types of approach, the transperitoneal and the retroperitoneal approach. And how you establish the pneumoperitoneum. Is it through the open technique or is it through the closed technique, as I've described before? So now you have decided that you want to go transperitoneal and you want to establish the pneumoperitoneum through an open technique. But how do you place the ports? Before that, you need to have some knowledge about certain angles. Okay, so the first one that you see right over here, I have tried to recreate these angles. The one on the left side, you see that there is a triangle. This is the triangle that you see. This is the kidney. This is the shape of the kidney. I've tried to make it, but try to make it as accurate as possible, but it is how it was made. Anyway, so this is the angle, and this is the angle that is made between the working instruments, that you're holding in your hand. The angle that is produced in between these two is 60 degrees, and it is directed towards the hilum of the kidney in order to provide the comfort to the surgeon, to the operating surgeon. It might be too close, it might be too far, but that would be very cumbersome. So this angle is 60 degrees, and this is called as the manipulation angle. The other angle that you see is between the camera port and the working instrument. This is a 30-degree angle on both the sides, 30-degree here and 30-degree over here. This is known as the azimuth angle. This can be offset by the surgeon, because a lot of us with big bellies, the surgeon with big bellies, the camera guy who is supposed to, handle the camera, he might touch his belly all the time. So you can offset this angle as well. So it's according to the surgeon's comfort. Now on the right side, there's an elevation angle. The elevation angle is basically the angle between the working instrument and the skin of the patient. So this is the angle basically that is being made. So the surgeon should have both his elbows by his side and should be in a comfortable position to operate. So these angles are some things that you should know before operating on a patient. Okay, so how do you place the trocar? What are the optimal positions for trocar placement? You need to understand that okay. So you need to understand that these are some of the common sites of trocar placement. You need to know the anatomy of the deep and the superficial vessels as well, because during trocar placement, you can damage these vessels. The common site for placement is the umbilicus, above the umbilicus in the midline and the left upper quadrant. You can see on the right side in the diagram, the inferior epigastric is there, the superficial epigastric artery is over there, and the superficial circumflex iliac artery is over there. You need to avoid this during trocar placement. Okay. So, how do you establish the pneumoperitoneum? So, once the trocar is in place, you attach the insufflation tube. Now, so the insufflation device has two parameters. Number one is the pressure. The other one is the flow. The pressure, which is usually the preset pressure and the actual pressure. These are the two settings on the insufflation device. The preset pressure is the pressure that the surgeon sets itself. That ranges from 12 to 15 mmHg, which is the optimal pressure for creating an intra-abdominal pneumoperitoneum. The actual pressure is the actual pressure that is being produced inside the intra-abdominal cavity. The flow, the insufflation device also shows you the flow. So the flow varies from 0 to 45 liters per minute. It should be ideally be less than 1 liter per minute, because more than that, you risk the patient to undergo an air embolism. So, and the other thing that can happen is if it is more than 7 liters per minute, the patient can have hypothermia. And you ask why? Because carbon dioxide is the gas that we are mostly using, and the carbon dioxide is delivered very cold. But the one that we use over here is at room temperature in order to avoid the hypothermic reaction. So about 1.5 liter of carbon dioxide is needed to achieve a pressure of 12 millimeter Hg. And the carbon dioxide that is delivered to us is usually at room temperature 22 to 25 degrees Celsius, and it is dry with a maximum of 5% humidity. You want to establish a pneumoperitoneum, but now you're running into trouble because the abdomen is not expanding. What do you do? Firstly, you need to check in the trocars. Are the trocars in place? A low flow and a low pressure indicates that the gas tank might be empty. A low flow and a high pressure indicates that there might be an obstruction, kinked tube, turn-off valve, or a preperitoneal insufflation. A high flow and a low pressure indicates that there might be a gas leak. You have heard that hissing sound coming from within the trocars. That is the gas leak. And if you look at the insufflator, it would show a high flow, but the pressure would be on the lower side. So after you have established the pneumoperitoneum, you need to have some physiological consideration during the surgical procedure. The number one important parameter is the selection of the gas. Again, carbon dioxide is what we most commonly use. Why? Because it is colorless, it is soluble in water, it is non-combustible, and it's inexpensive. But the problem lies with carbon dioxide is it can cause hypercarbia, hypercapnia, and cardiac arrhythmias. And also patients with COPD have a decreased washout of carbon dioxide, which can lead to complications. Hence, the use of helium instead lowers these rate of complications. So, on the other hand, the other parameter that we need to understand is the pneumoperitoneum. So, the pressure inside the intra-abdominal cavity should be around 12 to 15 mmHg, which is optimal for cardiac parameters. Anything above that for longer period of time can have certain complications, mostly cardiac complications. So at this intra-abdominal pressure, you also decrease the complication of having oliguria. It lowers the post-op pain, which is something that you need to have your eye on. But if you have a pressure that is more than 20 millimeters, then suboptimal changes starts to occur in the human body. The changes that do occur in the human body during the pneumoperitoneum are number one, the hemodynamic changes. So what happens? If you insufflate carbon dioxide, it increases the intra-abdominal pressure, which in turn reduces the venous return due to the compression of the inferior vena cava. Then there's a cascade. It decreases the cardiac output, which causes hypotension. And because of that hypotension, there's an increase in the heart rate as well to compensate for the reduced stroke volume and the cardiac output. This compensatory mechanism can lead to tachycardia during the surgery. And then because of the systemic vasculature resistance, there is increased catecholamine release due to the stress and the pain, which can predispose the patient to arrhythmias, especially with those having underlying cardiac problems. Then once again, because of the sympathetic stimulation during the intra-abdominal cavity pressure, there is increase in the system vascular resistance. The other change that comes is in the respiratory tract, which causes the change that basically occurs is due to the increased intrathoracic pressure and potential hyperventilation that happens to the patient during the laparoscopic surgery. So this can reduce the overall oxygen delivery to the tissues and affect the cardiovascular system. The patient has to breathe more. There is increased work of breathing, which changes the lung compliance and causes hypoxia or hypercapnia. There is also a ventilation perfusion mismatch too, where in the areas of the lung becomes well perfused but are poorly ventilated. So these are the respiratory changes that happens during the procedure. The most important other thing that happens during the procedure is the renal blood flow dynamics. So what happens? Because of the increased intra-abdominal pressure, there is altered blood flow to the kidneys. Okay? There is renal vasoconstriction because of the increased sympathetic nervous system activation, which further impairs the blood flow to the kidneys, which potentiates acute kidney injury, which can happen post-operatively as well. You might have seen a lot of patients having increased creatinine levels post-laparoscopic surgery, and this is mostly because of that. The other thing that happens are the metabolic effects. So there is an acid-base imbalance too. Because of the increased absorption of carbon dioxide, the patient experiences metabolic acidosis, which may also affect the renal functions. And the electrolyte imbalance that usually happens, including hypokalemia and hyponatremia as well. This is all because of the renal perfusion that is being hampered during the procedure. The other important thing that you see is the decreased urine output. A renal perfusion is, obviously it's decreased, and there be corresponding decrease in the urine output, which is a critical indicator of the renal function during the surgery. You need to have that eye upon your urine output too. So the cardiac changes, the respiratory changes, and the renal blood flow changes. These are the three important things that happen during a laparoscopic procedure. And all of these should be known by the surgeon in order to carry out a safe laparoscopic surgery. Not that laparoscopic surgery is safe. It's usually safe if you know all the parameters. Here's a chart that shows the cardiovascular changes, the renal changes, and the respiratory changes that happens during the increase or decrease in the pressure. As you can see on the right-hand side, if the patient is experiencing a pressure of 5 to 10 mmHg, all the parameters are mostly normal. But as you go above 20 mmHg, the cardiac output starts to decrease because of the venous return also sort of decreases in this 20 mmHg, and the vascular resistance increases, the mean arterial pressure increases, and so is the heart rate. There's another one over here that shows 40 mmHg. At 40 mmHg, this is very dangerous because at 40 mmHg, the cardiac output decreases, the venous return decreases, the systemic vasculate, the vascular resistance is increased, the mean arterial pressure is also increased, and the heart rate decreases significantly. Not only that, because of increased pressure, the glomerular filtration rates drop drastically. And so is the urine output, which is very dangerous to the patient. The respiratory parameter shows that the end-tidal carbon dioxide also increases in the system. The carbon dioxide within the system also increases. Hence, the arterial pH decreases, leading to metabolic acidosis. So these are the things that happen during a high intra-abdominal pressure. So this is the reason why you need to avoid such high pressures during the surgery. So laparoscopic surgery is not only safe, but it also comes with its own complications. So some of the complications that we see, number one is during the pneumoperitoneum. So when you're placing the trocar, you might end up in the preperitoneal place, okay, preperitoneal place, and then you're insufflating the gas. The bleeding at the sheath side, the vascular injury that can happen, and the visceral injury that can happen too. The complications that occur during insufflation could be bowel insufflation. You have put in a Veress needle, and that Veress needle is there inside the bowel, and you have attached the insufflation tube. Now the bowel expanding. This is one of the complications. Gas embolism. Due to increased pressure inside the intra-abdominal cavity, the gas gets absorbed within the system and can cause gas embolism. If you're using any other gas except for carbon dioxide, mostly nitric oxide or helium, those gases are, like I said, poorly soluble, and there's a high chance of having gas embolism, which is showed by an acute cardiovascular collapse, dysarrhythmias, tachycardia, cyanosis, and pulmonary edema. And during insufflation, barotrauma can also happen. There are certain patients which have blebs in their lungs, and because of the high pressure, these blebs can burst. Subcutaneous emphysema, pneumomediastinum, pneumothorax, and pneumopericardium. There are some complications which are related to the surgical procedure as well. So the trocar position related problems, you don't have the trocar at the right place. Thermal and mechanical injury of the bowel. Thermal injury by the monopolar and the bipolar that you're using. Mechanical injury by the trocar that you might have placed or the instrument that you're working on. Vascular injuries. You might have seen a lot of vascular injuries during this laparoscopic procedure as well. When we're doing a nephrectomy, a lot of times, I haven't seen this in my real life before, but you can puncture the IVC as well, or any lumbar vein or whatever. So you can also injure the vasculature system. Nerve injury because of the position of the patient during the procedure, and any of the visceral injuries. Okay, so these are some of the complications that you might see. There are some early post-op complications too. After the patient is out of anesthesia, is in your ward or in the ICU, the patient might complain of pain, he might have ileus, a bladder injury that was there during the procedure, but it was taken and it was identified post-operatively. A urethral injury can also be identified post-operatively, pancreatic injury, splenic injury, a lymphocele formation, incisional hernia, and wound infection. So after all this, like I said, laparoscopic surgery isn't always safe. You need to be safe. And these are some of the complications that you normally see during the procedures. Okay, so how do you train in laparoscopic surgery? As you might have known, we do have the skill lab in our hospital where we have instruments like the box trainers and the virtual reality trainers. For all the residents over here who aspire to become a laparoscopic surgeon should always complete their hours on those laparoscopic trainers. So these are very important because once you start doing this, you get the precision in your hands. And then when you actually operate on the actual patient, then you would realize how safe you are as a surgeon, because that is the one thing that is of utmost importance during any minimal invasive surgery. That is the safety of the patient. Okay, so all of you who are into training or who want to become a laparoscopic surgeon in the future, or who are even training right now as well, should always use these laparoscopic box trainers and virtual realities and complete your minutes and then go on to the actual patient.
Thank you.